Hi, I'm Karen Joy and I'm here to present our paper, Data Work and Decision Making in Emergency Medical Services, a Distributed Cognition Perspective. This paper is co-authored by my advisor and mentor, Dr. Zhan at Pace University, and also my colleagues Ricky and Pradeepti, and also Dr. Adelgais and Dr. Ozkaynak from the University of Colorado. I want to begin this talk with our study motivation. The problem domain we examined was emergency medical service, which is a fast-paced dynamic service that deals with severe trauma and injuries after the occurrence of an accident or an emergency. EMS providers need to collect, integrate, and document patient data in real time and to support decision-making while performing hands-on patient care and examination. Many of the challenges in EMS are still understudied. They usually deal with collecting and making use of patient information, but there is an overall lack of empirical studies. And therefore, the goal of our presentation and our paper is to gain a comprehensive understanding of how EMS teams work, collaborate, and also what challenges exist in the field and how we can support them. Talking about the framework we've used in our paper, we have used distributed cognition as an analytical framework. It focuses on the interrelationship between people, artifacts, and work practices. It also helps us to understand how complex socio-technical systems work. Under the umbrella of distributed cognition, we've used three models, as you can see on the screen. First is the physical model, which describes physical level factors, such as the things which are heard, seen, can be accessed by individuals, and that directly impact a person's cognitive space. The second model is the information flow model, which focuses on the communication between the participating team members. And lastly, we have artifacts, which represent how artifacts support work or fail to support cognition. When we come to the methods, we performed video analysis. More specifically, we analyzed 25 video of EMS simulations. As you can see on the screen, we have 4 different camera angles, which allows us to see who says what and what is performed. Coming to the data analysis, 3 researchers transcribed these 25 videos using the framework mentioned before, and we generated a set of codes, which were organized broadly into 5 categories. The screenshot here shows a snippet of our analysis. Our results and findings showed that EMS teams leverage various mechanisms to distribute cognitive labor in managing, collecting, and using patient data. We observed a set of prominent challenges in the EMS data work, which we will see in the later slides. We have a lot of details in the paper, but here we mention only a couple of prominent findings. The first thing that we found was mechanisms of distributing cognitive labor in the field varied in various ways. We found that the overall EMS members and team members primarily relied on verbal communication. For example, they proactively reported or requested information and then made decisions together. Another peculiar thing we found was the team leader was the information hub of an EMS team, which meant he or she was not only requesting information, but also synthesizing received information and responding to inquiries, and also stating decisions for the patient's care as needed. We also found several artifacts in this setting which were used as cognitive aids. As you can see on the slide, the prominent circles, the red circles, they show how EMS teams use temporary artifacts as cognitive aids. They made notes and wrote down information on their gloves, on the notepads, on hands, and then they used these artifacts or exchanged these notepads to share information with the receiving hospital or with their co-workers while engaged in patient care. Despite the EMS providers using so many mechanisms to distribute cognitive labor, we found there were still challenges that were very prominently seen. First was the lack of detailed documentation. The EMS teams do not have a dedicated documentation person. The task of recording information is usually done by the team leader or other team members sometimes. However, they have to perform hands-on examinations and treatments on the patient while managing the team and also while taking care of the patient. Thus, they don't have time or the mental bandwidth to complete detailed documentation in real time. The second challenge we identified was EMS providers relied heavily on short-term memory to recall information. We observed many instances when they could not recall certain information. such as what had happened to the patient, how much dosage was given, etc. The third challenge we identified was situational awareness issues. Due to the lack of documentation and recall issues, we found that there was a lack of awareness and a lack of mutual information sharing. The fourth challenge we identified was miscommunication and lack of closed-loop communication. Our quantitative data confirmed our observation that about 18% of inquiries went unanswered while on the field. The next challenge was the real-time decision-making challenge that the EMS face. We observed that unlike hospital teams where the leader makes the decisions, EMS teams have a more collaborative problem-solving method and they have a more collaborative decision-making method, which improves the effectiveness of treatment, but in real time, there are a lot of difficulties when they make decisions together. And the last challenge we identified was issues in pre-hospital communication. Timely and accurate communication with the hospital and with the EMS teams is very important. For example, the patient needs have to be met and anticipated by the hospital before the EMS teams get there. EMS providers who reported the information to the hospital sometimes had difficulties recalling specific information, which might be attributed to the lack of documentation. Another challenge we saw in this faced by the EMS was the verbal report. The verbal report was conducted via radio, which was very brief. It lacked contextual information in the verbal sense, and it makes it difficult for hospital teams to anticipate the patient's needs. Lastly, after identifying these challenges, we want to talk about the implications of the study. In this presentation, I will focus on implications for technology design. I encourage you to take a look at our paper and read more about the other implications we've mentioned. Speaking of technology design, the first thing we believe is enabling rapid data collection in the real time. As we observed in our study, EMS team leaders have eyes and their hands are always associated with patient care. So they don't have time to interact with devices. They hardly even use the electronic medical record. We believe it's very important to develop novel technologies like the digital pen or smart glass, which allows hands-free collection and sharing of data. Secondly, we feel enhancing situational awareness and decision-making in dynamic medical settings is a must. It's important that we develop cognitive aids to do so, like a checklist or easy-to-access information presentation that providers can refer to while on the go. And lastly, facilitating information sharing and care coordination between pre-hospital teams and hospital teams. As we mentioned before, this can be very important and very crucial for the patient. That's why it's possible that we can use telemedicine or video-based system concepts, such as a smart glass, which can stream the first-person point of view to a remote collaborator and facilitate real-time communication and care coordination. Lastly, even though there are different technology solutions, it's important to ensure that these new technologies and systems are well integrated with the existing systems. So let me conclude my presentation by telling you 3 takeaways from our study. First, the EMS teams leveraged various mechanisms, example verbal communication or external cognitive aids to distribute cognitive labor in the field, which help them to manage, connect, collect, and use patient data. But we have elaboratively seen how EMS still faces a lot of prominent challenges, especially in the EMS data work. What we need is a novel technology and interaction modalities to support rapid information acquisition, integration, and sharing in time-critical and high-risk medical needs. Our continuing efforts include conducting design studies to derive system requirements for novel technologies that can reduce physical and the cognitive load of using computing devices by emergency care professionals. With that, I conclude my presentation. Thank you so much for watching. If you have any questions regarding our research, you can email me or my advisor at the emails shown on the screen. We also want to use this opportunity to thank our study sponsor, National Science Foundation, and also all the participants in the simulation. Thank you so much.